Hello everyone, this is Dr. Roslena Deremi Williams, and I'll be taking you on Leishmaniasis in your PCL 311. I hope you benefit from this interaction. Our outline will be looking at the introduction, the epidemiology of Leishmaniasis, major risk factors, pathophysiology, clinical manifestation, diagnosis, treatment, prevention and control, and you have some references at the end which you can look up later. Leishmaniasis is one of the neglected tropical diseases affecting very poor nations. The disease is found in parts of 88 countries in the North and East Africa. It is also found in WHO regions of the Americas, Mediterranean regions, European regions, and Southeast Asia region. Mass population movement have fueled the epidemic of Leishmaniasis, and it is more common in the rural than the urban area. Leishmaniasis is caused by a protozoa parasite form from over 20 Leishmania species. It is transmitted by infected female sandflies of the genus Phlebotomus or Luzomia, found in diverse vegetation like desert forests and rain forests. Over 90 sandfly species are known to transmit Leishmania parasites, and three main forms of the disease is known: the visceral Leishmania, cutaneous Leishmania, and mucocutaneous Leishmania. Over 90% of the mucocutaneous Leishmania cases occur in Bolivia, Brazil, Ethiopia, and Peru. There's one which is not the main form, but it's also part of the forms of the disease, which is referred to as the post-Kala-Aza dermal form of it. It is typically, that's Leishmaniasis is typically a vector-borne zoonosis. Some 70 animal species are responsible for carrying it as reservoir hosts, while human beings have somehow become accidental hosts to this parasite. In many geographic areas where Leishmaniasis is found in people, infected people are not needed to maintain the transmission cycle of parasite in nature. Infected animals such as rodents or dogs, along with sandflies, usually maintain this transmission cycle. However, in some part of the world, infected people are needed to maintain the cycle. This type of transmission, which is from human to sandfly to human, is called anthropootic. In areas with anthropootic transmission, effective treatment of individual patients can help control the spread of the parasite. There are major risk factors causing infection of Leishmaniasis. One is the social economic conditions. Poverty. If you remember in our introduction, we said it affects the very poor nations. So poverty increases the risk of Leishmaniasis. Poor housing and domestic sanitary conditions, such as a lack of waste management or open sewerage, may increase sandfly breeding and resting sites, as well as their access to humans. If you can picture, or you've been to the poor areas of Lagos, like Ajegunle, those are places that they are still making use of things like pit toilet. They are still making use of the behind the houses sewage are disposed anyhow, and in such places there's tendency for there to be a breeding ground for sandflies. The sandflies are attracted to crowded housing, as this provides a good source of blood meal. And if you also can picture all those densely populated areas like Ajegunle, Olodi-Apapa, and some other areas that are so densely populated, you find out that there are so many people. And also, if there's human behavior such as sleeping outside or on the ground due to the heat. Many people in such areas stay outside to sleep, to get some fresh air, especially with our lack of electricity, and this may increase risk. Malnutrition also is another major risk factor. Diet lacking protein, energy, iron, vitamin A, and zinc increase the risk that an infection will progress to a full-blown disease. Another risk factor is population mobility. Epidemics of both cutaneous, which we are going to look in details later, and visceral leishmaniasis are often associated with migration and the movement of non-immune people into areas with existing transmission cycle. What's this trying to say? It's saying that because people move from one place to the other, somebody can move from where they don't have such epidemic to where there are such epidemic, and that can lead to transmission of leishmaniasis to such an individual. Also, occupational exposure as well as widespread deforestation remains important factors. They mostly reside in the forest, so as the forests are being reduced, trees are being cut and they are released to the surroundings, and that can cause be one of the major factors. Environmental changes also is a major risk factor, in that the incidence can be affected by changes in urbanization and the human incursion into forested areas. Still all about deforestation again. And the last but not the least of the major risk factor is climate change. Leishmaniasis is climate sensitive as it affects the epidemiology in several ways. Changes in temperature, rainfall, and humidity can have strong effects on vectors and reservoir hosts by altering their distribution and influencing their survival and population sizes. Small fluctuation in temperature can have a profound effect on the developmental cycle of Leishmania promastigotes in the sandflies, allowing transmission of the parasite in areas not previously endemic for the disease. Drought, famine, and flood can lead to massive displacement and migration of people to areas with transmission of Leishmania, and poor nutrition could compromise their immunity. So as you see, the major risk factor kind of are interwoven. We have cases of Leishmania HIV co-infection. In Leishmania HIV co-infected people, they have high chance of developing the full-blown clinical disease, and they also have high relapse and mortality rates. So antiretroviral treatment usually reduces the development of the disease, it delays relapses, and it increases the survival of the co-infected patients. High Leishmania HIV co-infection rates are reported from Brazil, Ethiopia, and the state of Bar in India. And this shows the life cycle of Leishmaniasis. The first stage here is where the sandfly takes a blood meal from a human being, and while it's taking that blood meal, it injects promastigote stage into the skin. And when that goes into the skin, the promastigotes are phagocytized by macrophages or other types of mononuclear phagocytic cells. That's when the human stage starts. Then these promastigotes transform into amastigotes, and these amastigotes, they will multiply in cells of various tissue and infect other cells, and that goes on infecting other cells. And while it is at this stage, the sandfly comes again, take a meal, ingests macrophages infected with amastigotes, and then inside the mosquito inside the sandfly, there's injection of the parasitized cells, and the amastigotes transform into promastigote stage in the gut of the sandfly, and it also go on to divide in the gut and then migrate to the proboscis, and the cycle repeats itself when it now take a blood meal from a human being. The cycle is described in this next slide. So, the clinical presentations. There are several different forms of leishmaniasis in people. Some people have a silent infection without any symptoms or sign. But we have those which in our introduction we mentioned, cutaneous leishmaniasis. This is the most common form of leishmaniasis. It causes skin sores on exposed parts of the body, leaving lifelong scars and serious disability or stigma. Then it typically develops within a few weeks or months of the sandfly bite. The sores can change in appearance and size over time. It starts as papules, which are like small bumps, or nodules, which are like lumps, and may end as ulcers. The ulcers are like a volcano. You picture a volcano, the shape of a volcano with a raised edge, and there will be a central crater inside. You will see that in the picture later on. Then there's skin ulcer. The skin ulcer may be covered by scab or crust. Then the sores are usually painless, but in some cases they can be painful. Then some people have swollen glands near the sores, e.g., for example, under the arm, if the sores are on the arm or on the hand. There is a variable tendency for lesion to self-cure within approximately 2 to 6 months. After 2 to 6 months, some of these lesions they go away on their own. We have, for example, in the Leishmania major, for Leishmania mexicana, it takes 3 to 9 months, 6 to 15 months for Leishmania tropica and Leishmania brasiliensis, and then 45 months for Leishmania panamensis, for example. Then the second form of Leishmania is visceral leishmaniasis. It affects several internal organs, usually spleen, liver, and bone marrow, and this can be life-threatening. Illness typically develops within months, sometimes as long as years of the sandfly bite. The affected people usually have fever, and this fever is usually associated with rigors and chills, and may be intermittent. They also can have fatigue and weakness. And then there's weight loss, enlargement of the spleen and liver, and there can be low blood count, like anemia when there's low red blood cell count, leukopenia when the white blood cells are low, and thrombocytopenia when the platelets are low in number. The clinical symptoms are similar in the various endemic areas, but there are some differences too. Mucosal leishmaniasis is an example of one of the less common forms of leishmaniasis. It leads to partial or total destruction of the mucous membranes of the nose, the mouth, and the throat. This can disfigure that part of the body. This form can be a sequelae, which is a consequence of infection with some of the species of the parasite that cause cutaneous leishmaniasis in parts of Latin America. Certain types of the parasite might spread from the skin and cause sores in the mucous membrane of the nose, which is the most common location. The nose is the most common location. So it can cause sores in the mucous membrane of the nose, mouth, or throat. The mucosal involvement first manifests as unusual nasal symptoms, e.g. epistaxis, with erythema and edema of the nasal mucosa. So in the nasal mucosa, there's swelling and it's red. It's looking reddish from the erythema is causes. Then by progressive ulcerative destruction of the nasopharyngeal mucosa is the end point of the mucosal involvement. Then we also have it's not one of the main forms, but we have the post-calaza dermal leishmaniasis, and it follows after the treatment of visceral leishmaniasis. It has predominantly been described in Africa, about 2% of the cases, and India, about 10% of the cases. The Indian variant occurs in patients 1 to 2 years and as long as 20 years after recovery from visceral leishmaniasis. This condition is characterized by multiple hypopigmented erythematous macules. Over time, these macules can transform into large, non-tender plaque and nodules that involve the face and the trunk. The disease resembles lepromatous leprosy and requires intensive therapy. The African variant occurs shortly after treatment of visceral leishmaniasis and is characterized by an erythematous papular rash on the face, buttocks, and extremities. These lesions spontaneously resolve over the course of several months. And as you can see, these are the picture. You can view the cutaneous form. You can see the visceral one is not here, but you can see the mucocutaneous form of it, and the last one we just discussed. Diagnosis. Various laboratory methods can be used to diagnose leishmaniasis, and it is meant to detect the parasite as well as to identify the Leishmania species. In visceral leishmaniasis, diagnosis is made by combining the clinical signs with parasitological or serological tests, such as rapid diagnostic tests. Blood tests that detect antibody and immune response to the parasite can be helpful for cases of visceral leishmaniasis. Tests in cutaneous and mucocutaneous leishmaniasis, serological tests have limited value, and clinical manifestation with parasitological tests confirm the diagnosis. Tissue specimens such as from skin cells for cutaneous leishmaniasis or from bone marrow for visceral leishmaniasis can be examined for the parasite under a microscope in special cultures and by molecular tests. Treatment. There are certain considerations before treatment. Before considering treatment, the first step is to make sure the diagnosis is correct. Treatment decisions should be individualized. Factors to consider include the form of the leishmaniasis, the leishmania species that is causing it, the potential severity of the case, and the patient's underlying health. Given the associated morbidity, always treat visceral, mucocutaneous, and severe forms of cutaneous leishmaniasis. Patients should receive treatment at facilities experienced in treating the disease as per latest guidelines. Owing to its potential to progress into mucocutaneous leishmaniasis, definitely treat New World cutaneous leishmaniasis caused by members of the L. Leishmania viania subgenus. Cases due to Leishmania tropica and some Leishmania major from certain regions of Afghanistan may have a more aggressive or chronic course, up to years. The patient might experience it for years. The Leishmania tropica has been implicated in occasional cases of recidivans or viscerotropic leishmaniasis. As such, treatment may need to be more involved in cases caused by this species. The pharmacotherapy. 6 forms of pharmacotherapy approaches are used. One is with antiparasitic pentavalent antimonial agents. 2 is with liposomal amphotericin B. 3 is with oral miltefosine. 4 is with pentamidine. 5 is with other agents, and 6 is with antibiotics. With antiparasitic pentavalent antimonial agent, this has been the treatment mainstay of leishmaniasis. It was first introduced in the 1930s. The 2 available preparations are sodium thibogluconate, also referred to as pentostam, produced in Great Britain. As the second available type of preparation is meglumine antimonate, also referred to as glucantine, produced in France. They both have similar efficacy. Depending on the species and region, cure rates of 80 to 100% have generally been reported. In many regions of the world, direct intralesional injection of pentavalent antimony is used to treat cutaneous disease, although this can be painful and is technically difficult. The first type, which is sodium thibogluconate, is only available from CDC under an investigational new drug protocol. This agent has been for the treatment of cutaneous and mucocutaneous leishmaniasis in the United States. It has also been the drug of choice in the treatment of visceral leishmaniasis, except for in Europe and regions in India with thibogluconate resistance. Prior full evaluation should be made before the use of this drug. Periodic evaluation of cardiac conduction with electroencephalographic monitoring is prudent. Laboratory assessment of complete blood counts, renal functions, and amylase, lipase, serum, transaminases levels should also be performed. In cutaneous leishmaniasis caused by L. viania panamensis, the efficacy of a 10-day course was validated with a significantly reduced side effect profile over the standard 20-day course. However, the results may not be applicable to infections caused by other species of Leishmania. The second form of pharmacotherapy is with the use of amphotericin B. It is effective against pentavalent antimony-resistant mucocutaneous disease and visceral leishmaniasis. Its use is limited because of its toxic adverse effect profile. The newer lipid preparation, amphotericin B lipid complex, liposomal amphotericin B and amphotericin B colloidal dispersion, are more active, better tolerated, and are being used as first-line therapy against visceral leishmaniasis. But the response with cutaneous disease has been mixed, and treatment is costly. Liposomal amphotericin B is the drug of choice for visceral leishmaniasis because of its shorter course and lower toxicity. Treatment with liposomal amphotericin, single dose treatment with liposomal amphotericin B has shown a 91% cure rate in India. In endemic areas of North India, liposomal amphotericin B is used in combination with miltefosine, a short course regimen consisting of a single dose of liposomal amphotericin B followed by 7 to 14 days of miltefosine has resulted in cure rates of over 90%. Response to liposomal amphotericin B may be suboptimal in patients infected with HIV. The third form is oral miltefosine. Response to liposomal amphotericin B may be suboptimal, like we mentioned earlier, in patients infected with human immunodeficiency virus. In March 2014, the FDA approved oral miltefosine for visceral leishmaniasis due to Donovani, Leishmania donovani, cutaneous leishmaniasis due to Leishmania brasiliensis, Leishmania guianensis, and Leishmania panamensis, and mucosal leishmaniasis due to Leishmania brasiliensis. The FDA approval was for patients who are aged 12 years or older and weigh at least 66 pounds and are not pregnant or breastfeeding. Common toxicity and side effects of miltefosine are vomiting and diarrhea. Elevation in the hepatic transaminase and serum creatinine has been reported, but is usually mild and resolved as soon as the drug is stopped. We have the fourth pharmacotherapy, which is intramuscular pentamidine. It is effective against visceral leishmaniasis, but this drug is associated with persistent diabetes mellitus and disease recurrence. Pentamidine is a drug of choice to treat Leishmania guianensis in French Guiana, where antimonial resistance is prevalent. Other agents used in treatment are orally administered ketoconazole, itraconazole, fluconazole, allopurinol, and dapsone. They have been examined internationally, but none is as effective as the pentavalent antimony compound. However, given their minimal adverse effect profile, these agents may be useful in accelerating a cure in patients with cutaneous leishmaniasis that does not progress to mucosal disease and tends to self-resolve. Dapsone was shown to be effective in most cases of Indian cutaneous leishmaniasis after 6 weeks of therapy. Ketoconazole has a variable cure rate for the New World cutaneous leishmaniasis depending on the species. Fluconazole was reportedly effective against 70% of patients infected with uncomplicated cutaneous leishmaniasis caused by Leishmania major in Saudi Arabia. The sixth form of pharmacotherapy that is also usually employed is antibiotics. Patients with leishmaniasis may have concurrent systemic illness or local infection. Visceral leishmaniasis is an important opportunistic infection associated with AIDS. So patients who are infected with HIV can develop unusual manifestation of leishmaniasis. The guideline for prevention and treatment of opportunistic infection diseases in patients with HIV infections have been established. So there is prevention and control. The prevention and control of leishmaniasis require a combination of intervention strategies because transmission occurs in a complex biological system involving the human or animal reservoir hosts, parasites, and sandfly vector. No vaccines or drugs to prevent infections are available. The key strategies for prevention are listed below. A. Early diagnosis and effective prompt treatment. This reduces the prevalence of the disease and prevents disabilities and death. B. Vector control. Helps to reduce or interrupt transmission of the disease by decreasing the number of sandflies. The control methods include insecticide spray, use of insecticide-treated nets, environmental management, and personal protection. People should avoid outdoor activities, especially from dawn to dusk, when sandflies generally are most active. The third way for prevention and control is effective disease surveillance. It is important to promptly monitor and act during epidemics and situations with high case fatality rates under treatment. Then, control of animal reservoir hosts is complex and should be tailored to the local situation. It's difficult to control animals as the reservoir hosts. That's a very difficult thing. So, depending on the environment, if a particular animal has been identified as being the host, then the necessary precautions have to be taken. Prevention mechanisms have to be taken to make sure that they don't transmit to humans. Social mobilization and strengthening partnership. Mobilization and education of the community with effective behavioral change intervention must always be locally adapted. The dangers of sleeping outside, the dangers of deforestation, the dangers of exposing one's skin in areas where there can be sandfly, not being wearing proper clothing. All these things, education on making sure their houses are netted and this, if possible, they sleep under nets or make sure the rooms are flatted to avoid a sandfly, because these sandflies are even smaller than mosquitoes in some cases. So some of these nets might not be as effective as for mosquitoes. Partnership and collaboration with various stakeholders and other vector-borne disease control program is critical. Thank you very much. These are some references which these notes were taken from. If you need to read more, you can